reason why today I'm going to be doing a video on rate control, rhythm control. I'm going to make it easy, as I always do. Easy for you, atrial fibrillation. So let's do this together. Let's stop all the confusion. You know what Marvin does? Marvin makes things fun and Marvin makes things easy for you, all your clinical knowledge. So let's go. So what we're going to look at today is we're going to look at AF, atrial fibrillation. So I'm not going to go into so much detail. You could watch some of my YouTube videos, or you could join our course, and there's so many notes on atrial fibrillation and so much information to help you. But what I want to do today is I want to help you with the confusion with rate control, with rhythm control, with cardioversion, with when to use what strategy. Okay, so this is the first part where many of you get confused. If you're watching this now, you're probably one of them that gets confused about this. So this is the first thing. I want you to write this down. So we have two types. There were two types. When we talk about atrial fibrillation, the first thing you want to ask yourself is, what are we looking at? Are we looking at an acute presentation or a non-acute presentation? It is so important, and later on you're going to say exactly why I'm saying this. So the first thing you do is I'm going to write on here acute, and I'll write over here non-acute. So by acute, what do we mean? We just mean severe, right? So when I talk about acute, this is when your atrial fibrillation is very severe. Probably just walked into the emergency. So this is normally dealt with accident emergency. While a non-acute is probably an AF that you've had for a while. An AF is just an abnormal heart rate. So you could watch some of my videos on YouTube where we'll go into details about the different types of atrial fibrillation. But when we talk about acute, we need to know the difference between both in order not to get confused. So we've got acute presentation and we've got non-acute presentation. So why are we focusing on this difference? The reason is because if you understand these differences, there are also different strategies on how to treat them. Okay, so let's focus on this one. So we're going to start off with non-acute presentation. So if a patient has got a non-acute presentation, that means this not as severe. When we talk about severe, we're looking at what are the symptoms that we're looking at when we talk about atrial fibrillation. We're looking at things like shortness of breath. We're looking at things like a very, very low blood pressure, say maybe less than 90 systolic. So these are sort of presentations, breathlessness. So if the patient isn't an acute patient, it's a non-acute AF, then this is what we do. We've got two strategies to treat them. So what do? We could either treat them by using rate control or rhythm control. So this is step number one. We've got rate control and we've got rhythm control. Remember, we are talking about non-acute patients, all right? We're going to look at acute later on. So that's the first distinction you need to make. If you don't make this distinction, you're going to be confused. So once you know this, I'm going to put something here to help you. When it comes to non-acute patients, the priority is rate control. So I'm going to put one, then I'm going to put two. What does this mean? This means in terms of the treatment strategy, rate control is the preferred, is the first line strategy for treating any patient with a non-acute atrial fibrillation. And then the second choice, so option, is rhythm control. Now, another area where many students get confused all the time is this is the first line, but this doesn't mean we cannot use the second line, okay? So being the preferred strategy doesn't mean you cannot use rhythm, right? So let's focus on rate control. So let's look at rate control. So when we talk about rate control, we're looking mainly at tablets, right? We're looking at pharmacological treatment with this strategy. So what do? If a patient is non-acute presents with atrial fibrillation and that atrial fibrillation is not acute, then we can give them with either a beta blocker, so I'm going to put BB, or calcium channel blocker. So these are normally rate limiting calcium channel blockers like verapamil, like diltiazem. So beta blocker or calcium channel blocker. How do we choose or decide which one to give? So do we choose a beta blocker and not sotalol, by the way, just standard beta blockers? Do we give a beta blocker or do we give a calcium channel blocker? Common question people ask. It doesn't matter. It all depends on the patient. So patient preference. Has the patient got some comorbidities? For example, if that patient has got heart failure, or if the arrhythmia was caused by heart failure or has any connection with heart failure, then we don't want to give them a calcium channel blocker. We want to avoid calcium channel blockers with patients with arrhythmias that have got heart failure. So in that case, you're going to go for a beta blocker. So what is the point? What I'm trying to emphasize here is it doesn't really, you don't have to start off with a beta blocker. It all depends on several factors with that patient, comorbidities, heart rate, and different things, or patient preference. But majority of the time, it's encouraged to use a beta blocker compared to a calcium channel blocker. So we use either or. So what happens if this still doesn't bring your rate down? So we'll try to control the rate. So if this doesn't improve the rate of the heart, then we can do the second thing. We can either increase the dose of your beta blocker, or what else can you do? Or you could increase the dose of the calcium channel blocker if that's what you gave. Now, if you use one, it's what we call monotherapy. We'll normally start with one drug, okay? Monotherapy first. You're going to use one of these first. Now, what happens if this doesn't work? This doesn't improve, this doesn't reduce the heart rate, doesn't improve the heart rate? Then what we do is we could give 2 tablets together, 2 drugs together. So we're going to go to, we could give a beta blocker plus calcium channel blocker, or it could be a beta blocker plus digoxin, for example. So we can mix this up with different combination, BB and digoxin, or CCB and digoxin, or just a BB and a CCB. All right, so this is dual therapy. So that's number 2. We're giving 2 drugs. So non-acute AF, preferred strategy is rate control. What do? We give a beta blocker or a calcium channel blocker. If that doesn't improve the situation, we could then give them 2 drugs, beta blocker and calcium channel blocker, for example. And if this doesn't improve, despite doing all of this, then we could then change to rhythm control. Okay, so we'll go to our second option. Or you could use what we call an ablation strategy. But this is what happens. So if this isn't working, we could then move on to rhythm control. So let's look at rhythm control. So with rhythm control, we've got 2 important things you need to know. So with the rhythm, we can either treat you using pharmacological intervention, so using drugs, or give you what we call electrical cardioversion. Maybe we'll get confused and they go, oh, cardioversion, is this rhythm or is this rate control? What is it? So electrical cardioversion is rhythm control. So it's a type of rhythm control. Or we could give you drugs, what we call pharmacological rhythm control. So in terms of the drugs, we're looking at FAB. Most of you know this from the combo course. We talk about fabulous rhythm. These are the main drugs we could give. Right? These are the main ones. You can still give sotalol and other drugs, but these are the main ones. So FAB is for flecainide, A is for amiodarone, and B is for your beta blockers. When do we give which? Again, it depends on the patient. If this patient has got any sort of ischemia, any sort of structural heart problem, then it's better to give them amiodarone. So avoid flecainide. If that patient has got ischemic disease, has got heart problems, structural issues, then amiodarone is preferred. So this is really what you need to know for non-acute AF. So we'll give pharmacological presentation, pharmacological treatment if we are going down that route, or we give electrical cardioversion, which is just an electric shock. Right? So we've got different options. Another thing I'm going to point out for you of that rhythm control is you've got some patients that may have what we call paroxysmal AF. And what paroxysmal simply means is these are not permanent atrial fibrillations. They come and go. Right? They come and go like a common cold. Right? So you might have them for about 7 days, and then you don't have that arrhythmia, you don't feel the symptoms, and then symptoms are back again, and then they disappear and they're back again. With these sort of paroxysmal AFs, we could treat them with what we call a pill in pocket. So pill in pocket simply means you've got a few pills in your pocket, and you take those pills whenever you get paroxysmal AF or when you get the AF. Examples of your pill in pocket are your normal rhythm control pills. Again, you could have flecainide, or you could have amiodarone. So these are all examples of drugs that are used in your pill in pocket. So I hope this is making sense. I'm really trying to break this down. So we've looked at non-acute. These are the strategies that we will take with a patient with AF that is not acute. So you might treat them perhaps in a primary care setting, okay? So these are not as urgent. It might be a patient that's had AF persistently or for a while, for example. Now we're going to go on to this side, right? So we've looked at non. Now let's look at acute presentation. Acute presentation simply means this is a more severe. It may be a new onset. So it may be the first time they're having an AF. So this is a severe one. So under acute, we can divide this into two things. We could say with your acute, you can either have, if someone presents for the first time with an acute presentation, so the first time they're coming to an emergency with AF, they can either have what we call a life-threatening presentation, LT, which means that they have some sort of hemodynamic instability. We'll talk about hemodynamic instability. We're just saying it's quite serious. So you might have they'll present with some breathlessness. The patient will probably be breathless. Again, serious hypotension, very low blood pressure, maybe even syncope, maybe they fainted, or a lot of dizziness. So these are very urgent symptoms. So that's what we call life-threatening. So under acute, the patient could either have a life-threatening acute presentation, which is your hemodynamic instability, or the patient may not be life-threatening. So the situation may not be life-threatening. So I'm going to put N for not life-threatening. So you've got life-threatening and you've got not life-threatening. So why am I emphasizing on this too? Because based on this, that will determine how you treat them. This is a lot of confusion. This is why many people get confused between this, but I'm making it easy for you like I always do. So if the patient has got life-threatening, so Mr. Bloggs comes into the emergency, it's an urgency, has been brought in by the ambulance, he's suffering from AF, and that AF is life-threatening because with the AF, the patient cannot breathe, blood pressure is dropped massively below 90 for systolic, patient is dizzy or very breathless, and this patient is actually fainted. Then what we need to do in this emergency is we could only treat them with one first option, which is electrical cardioversion. So this again is rhythm control. So for these type of patients that are in an emergency situation, we treat them with rhythm control, which is electric cardioversion. So like shock the heart, okay? And with this, you don't need to give them any anticoagulants because it's an emergency. There's no time for us to give them anticoagulants. So you're going to ask me, why do we have to give them anticoagulants? The reason why we have to give anticoagulants is because anyone that's about to undergo this process of electrical cardioversion has an increased risk of getting a stroke. So electrical cardioversion will increase your risk of having a stroke. So in order to prevent that, we need to make sure that whoever is going to have any electrical cardioversion, this patient has to be anticoagulated. In this situation, because of the emergency, there is no time to give you any anticoagulation. So what we do is we go straight into electrical cardioversion. Very important, this is for acute, life-threatening hemodynamic instability or life-threatening AF. What's the treatment? Electrical cardioversion straight away. So let's look at the other situation. So what if that patient did not have a life-threatening arrhythmia? Okay, so what if it wasn't life-threatening, which means they were not presenting with all of the symptoms of breathlessness, syncope, dizziness. So it's not hemodynamic unstable. Okay, so it's not unstable. So in that case, this is so interesting. Then you've got two choices. You can either treat this patient with rate control, or you can treat them with rhythm control. Actually, let me wipe that out. But before that, this is so important. Yes, okay, this is so important. If this is not threatening, patient presents to the A&E, very important, comes in an urgency, and the patient doesn't have a life-threatening atrial fibrillation, which means they're simply not presenting the symptoms as such, then you need to ask one question. How long have they had this for? Right? Have they had the AF for more than 48 hours or within 48 hours? If so, with non-life-threatening, you ask the question about the duration, okay? And the main one we'll look at is 48 hours. How long have they had it for? If this patient has had it for less than 48 hours, so they can either have it for less than 48 hours or they can have it for more than 48 hours. Or perhaps we could say, we don't know, right? It could be longer, maybe we don't know exact duration. So if you know exact duration, that's fine. If you don't know, that's fine, you could go over there. So with the non-life-threatening acute presentation of AF, we try to find out how long they've had this AF for. So let's say the patient has had it for less than 48 hours. They've just had it for a day or in the last few hours. What do you do? So we've got two choices. If it's less than 48 hours, we can treat them either with rate control or with rhythm control. So less than 48 hours, we could either treat them with rate control or rhythm control. But this is very important. This is where people get confused. In terms of priority, you go for rate control. This is the priority in this situation. This is the priority of rate control. So again, rate control, we've seen that on there, we can give them the rate control medication, or we can treat them again with them. We've got electrical cardioversion, or we've got pharmacological treatment. Okay. Hope this is clear. Hope you guys are learning this. I'm making this so easy, taking away all the confusion. Now, this is another thing that happens to most people and where they get confused. This is for less than 48 hours. We could give either or, but this is preferred. But what if it was more than 48 hours? Now, if it was more than 48 hours, if this was more than 48 hours, the preferred treatment is rate control. Okay, so we've got 48 hours. Less than 48 hours, we give rate or rhythm. But if it is more than 48 hours, the preferred treatment is rate control. But another area where people get confused is, if it says this is the preferred, so I'm going to give one priority, it doesn't mean you cannot give them rhythm control. So as we established earlier, there are certain patients that get given rhythm control straight away. So we have restrictions to rate control. So even though rate control is your first line, there are situations or patient circumstances that will require a rhythm control as the first line. So for instance, if this patient had, if the patient had a new onset of arrhythmias, a new onset that was very severe, that had those symptoms, for example, then we're going to give them rhythm control instead of rate control. If this patient had an arrhythmia, an AF, that was due to a reversible cause. So if you had a reversible cause, for example, you had a chest infection, if that's a reversible cause, then you're going to treat them with rhythm control rather than rate control. So the main point is this: don't get hung up. Most people get hung up and go, oh, it's got to be rate control, but no, why not rate control? It has to be rate control because rate control is the first line. In this situation, it could be also, you have to look at different factors for that patient. So rate control is the first line, but doesn't mean you cannot give rhythm control. Can we give rhythm control? This is more than 48 hours. Yes. So you could rate control, or I'm going to put this here. I'm going to put some dots like this, because you could also give rhythm. For example, if the patient for some reason is unable to have rate control for whatever reason, then you could give them rhythm control. But if you give them rhythm control in terms of priority, this is so important. We've got electrical cardioversion, like we mentioned, and we've got pharmacological. In this instance, if you were to choose between this or this for rhythm control, the first line will be electrical cardioversion, and this will be second line. So if it is greater than 48 hours, rate control, although this is preferred, if for any reason the patient cannot have rate control and you have to give them rhythm control, then the first line is electrical cardioversion over pharmacological cardioversion. So electrical cardioversion, as I mentioned, is a form of rhythm control. It's just electrical shocks. While you also have pharmacological cardioversion, which is not electrical. It's giving you your medications, which are literally your fabulous rhythm, your flecainide, your amiodarone, and your beta blockers. So I hope this makes sense. So I'm just going to summarize all of this for you. This is why people get confused. AF, first of all, number one, you need to make that distinction. There is acute and there is non-acute. Always ask yourself, what are we looking at? A patient presents to you in the hospital, right? It could either be an acute or a non-acute presentation. If it's a non-acute presentation, which means it's not life-threatening, or it's not a new onset, or perhaps they've had it for a while, then we've got different ways to treat them. We can either treat them by rate control, or we can treat them by rhythm control. So the question is, which one do we choose? It all depends on the patient. Now, in terms of your guidelines, the preferred first line is rate control. How do we do rate control? We're going to give them a beta blocker, and we'll always start off with one drug, monotherapy. It could either be a beta blocker or a calcium channel blocker, depending again on the patient. This patient may have heart failure. In that case, we're not going to give them a calcium channel blocker. We're going to give them a beta blocker instead. If one drug doesn't work, what do? We could increase the dose, or we give them two drugs, dual therapy. So now we've got a beta blocker and a calcium channel blocker. What if that still doesn't improve the rate? Then we can switch and we could do the second option, which is rhythm control. Or if that doesn't work, we'll give them ablation strategies, which I don't want to talk about in this video. Right. So if that doesn't work, we'll give them rhythm control. So what is rhythm control? How do we do it? With rhythm, we've got pharmacological interventions. So the treatment, pharmacological cardioversion, is your fab-ridden FAB, amiodarone, flecainide, beta blockers. Amiodarone is good for anyone that's got any heart structural problems. You give them amiodarone over, say, flecainide. You give them electrical cardioversion as well. If the patient's got what we call paroxysmal AF, so AF that comes and goes, then we give them a pill in pocket. A pill in pocket is preferred for paroxysmal patients. Digoxin here as well is normally for sedentary patients, so patients that don't move a lot, that have got non-paroxysmal AF. So that's non-acute. Now, if the patient had an acute presentation, an acute or serious presentation of AF, then we need to decide what type of AF is it. Is it hemodynamically unstable, or is it hemodynamically stable? Hemodynamic unstable simply means it's very serious. It's an emergency. This patient will present with breathlessness. This patient might faint in front of you. This patient might be dizzy. So all of those factors. Now with this, we don't need an anticoagulant because that's serious. We're just going to go straight into electrical cardioversion, and that's how we deal with acute with life-threatening symptoms. that if it was acute but it wasn't life-threatening, then we need to ask ourselves, how long has this patient had that AF for? Has it been within 48 hours or has it been more than 48 hours? If it has been less than 48 hours, then we've got two choices. We can either treat them with rate control or we can treat them rhythm control. If they've had that AF for more than 48 hours, then the preferred treatment is rate control. If for some reason we cannot give them rate control and we decide to give them rhythm control, then in terms of electrical cardioversion and pharmacological intervention, the first line is electrical cardioversion. So that's really it, ladies and gents. I hope that is really clear. I'm just going to talk about one thing about anticoagulation because I mentioned that on here. Normally with cardioversion, you normally will anticoagulate the patient about 3 weeks before electrical cardioversion. So that you could give them some warfarin or heparin, or it could be a DOAC, all right? A DOAC like rivaroxaban. So that's what you do before you actually attempt electrical cardioversion. It's normally 3 weeks of anticoagulation and then electrical cardioversion. But in this instance, when it's that serious, there is no time to give them or to anticoagulate the patient. You want to go straight into electrical cardioversion. I hope this makes sense. I hope you enjoyed this. I'm making this so easy and practical for you. If you want to learn more in the best, fun, exciting way to smash your exams, then you absolutely must join Pre-Read Shortcuts. So I think our website link is going to be at the bottom of this video, www.prereadshortcuts.com. Make sure you follow us, make sure you join us, because we are here to help you. Help your knowledge, improve your clinical knowledge, make it fun, make it exciting, make it easy. Once again, if you enjoyed this video, please hit the like button, hit the like so that I know you actually learned a lot from this video. And I hope this clarifies the confusion, and I look forward to seeing you all soon. Take care. Bye.